Jeevitha Jagannathan to come and deliver her talk on the baseline visual fields, the criteria for diagnosis. Dr. Jeevitha has 15 years of experience in ophthalmology. She did her MS from RIO Chennai and then the Clinical Glaucoma Fellowship at Shankara Nethralaya Chennai, and is currently working as proprietor of NNI Care in Chennai and a senior glaucoma consultant at the Amrit Group of Hospital and a visiting consultant in several centers across Chennai. She is keenly interested in academics and has several publications and presentations to her credit. Over to you, Dr. Jeevitha. Dr. Ratni shall be moderating the session. She is a senior consultant in Shankara Nethralaya, Chennai. A note to all the attendees, if you have any queries, we'll keep it for the end of the session, and you can ask all your doubts at the end of all the sessions. Thank you.
Can you hear me?
Yeah.
Good morning, everyone. Audible, sir?
Slightly.
Yeah. Good morning, everyone. Welcome you all to the field of glaucoma. So, perimetry is a technique of evaluating the visual field. It's a functional correlation of the neuronal loss associated with the disease. Baseline test is the test that defines the patient field status at a particular point of time, like at the beginning of the therapy or after major change in the treatment strategy or so on. It's always worthwhile to get two similar and representative baseline tests early in the course of the disease, apart from the learning curve. In order to get the best out of the visual field testing, we must be aware of what are the various testing methods, strategies, and patterns available, which test to be done at when and how. So, Goldman size 3 is commonly used stimulus size, and Goldman size 5 has to be chosen in patients with poor vision. Central fixation target is what we commonly use, and large diamond is used in eyes with poor central vision, such as macula pathologies, and small diamond is used for foveal threshold testing. These are the various threshold strategies available. Full threshold intensively tests each testing points by double bracketing strategy. So obviously it's time taking. Whereas the CETA strategies it reduces the time significantly by adjusting the intensity of the test stimuli provided based on the neighboring points intensity. And also it adjusts the testing time by it adjusts the time interval between each testing stimulus according to the patient response. This is the CETA standard. Fixation monitoring is done with blind spot monitoring, whereas in CETA Fast and Faster, it's done with the gaze tracking technology. This also helps in reducing the testing time. Full threshold takes around 15 minutes. CETA standard takes 5 to 8 minutes, and CETA Fast and Faster even more lesser. Which strategy to choose for your patient depends upon the concentrating ability and the age of the patient. And if you need more accurate information, such as if you see the patient is progressing or there is a vision loss due to glaucoma in the other eye, it's better to go for the longer test. In eyes with early glaucoma and glaucoma suspects, you can go with CETA Faster, Faster. These are the various test patterns available for testing. 24-2 is commonly used for glaucoma and 30-2 for neurological lesion, as we all know. 24-2 is just a 30-2 with this outer set of orange colored dots you see here removed. And 10-2 is concentrated on the central 10 degree of fields. Each test point is only 2 degrees apart. 10-2 is usually done in advanced field effect like this, which you see here in end-stage glaucomas. But I would like to stress a point here. 10-2 also has a role in eyes with early glaucoma, which involves the central defects. If you get to see a central defects in 24-2 like this, it's better to get a 10-2 also done. In this field, if you see, there are only 1 or 2 paracentral defects, but 10-2 shows significant depressed points. 24-2C is a newer pattern available with CETA Faster in HFA3 mission. This adds an extra set of 10 points to the 24-2 strategy. It's used for screening central involvement. However, if you're suspecting central defects, better to go with the 10-2 strategy for progression analysis and all. This is a 24-2C printout. You can see central points involved. Macula program is used only when central 5 degree of the field remains. If you are looking out for a macula split, get the macula program done. What is this printout? This looks like a MATLAB program, but if you look, this is a 24-2 done with the size 5 stimulus. So run through of single field analysis. This is a testing pattern strategy indicated here, reliability indices, grayscale map, threshold values, numerical total and pattern deviation plot, and probability plots of the same. Here are the global indices. Down is the grace tracking of the thing. False positive is the tendency of the patient to press the button even when no stimulus is seen or when it's very unlikely to be seen. We call them as trigger happy patients. False negative is seen in inattentive patients or in patients with fatigue. Increased false negative is also associated in eyes with significant field loss, though the patient is attentive. So false positive or false negative is preferable to be less than 15%. Fixation loss is preferable to be less than 33%. Test results should not be viewed as either reliable or not reliable. Actually, you should start seeing them as a continuum from highly reliable to a marginally informative thing. Like, you should not discard the test report solely based on the reliability indices. If the reliability indices are not that great, you have to read the report with little more caution. Grayscale helps in identifying artifacts or any obvious disease-specific field patterns. It's not of much use in glaucoma. Numerical threshold sensitivity provides the raw data of actual measured threshold sensitivity of each testing points. Total deviation quantifies how much it deviates from the age-corrected normal values. Pattern deviation highlights the localized loss after correcting for any generalized depression due to media opacities. Probability map is the probability of the same defects seen in the general population of less than 5%, 2%, or so on. It highlights the subtle but statistically significant variations. Glaucoma hemifield test compares the 5 zone in the upper hemifield with the mirror image of the same 5 zones in the lower field. These zones are sensitive to glaucomatous damage. Glaucoma hemifield test usually gives an easy idea to the beginners in field interpretation. Mean deviation is the weighted average of the values presented in the total deviation plot. More negative the mean deviation value, more the defects are. Pattern standard deviation summarizes the localized loss, ignoring the generalized depression, but it follows a non-linear pattern. If you see here, it's lower in both the normal and in the perimetrically blind field, and is highest in the moderate to advanced field loss. Because of its non-linear pattern, it's not generally used in progression analysis. Visual field index is an enhancement of the mean deviation that is less affected by cataract and more sensitive to the central field defect changes. So visual field index of 100% is seen in normal eyes, and it gradually deteriorates as the glaucoma worsens. Anderson criteria is what commonly we used for diagnosing glaucoma based on the field report. In pattern standard deviation plot, three or more non-edge points in case of 30-2 fields, and edge points are to be included in 24-2 with p less than 5%, at least one of which is with the p-value less than 1%. Pattern standard deviation less than 5%, and glaucoma hemifield test outside normal limits. If all three criteria are present, it's more suggestive of glaucoma, and if clinical diagnosis is more towards glaucoma, even one criterion is enough. These are the various staging systems available for staging glaucoma based on the field reports. Haddock Paris Anderson staging is what we are commonly familiar with, and this staging system by University of Sao Paulo includes the visual field index 2, and glaucoma staging system 2 by Brusini includes the Baby's curve of autopus. HPA staging provides a depth of overall defect thing based on the mean deviation value, the number of points involved on the pattern deviation plot, and its proximity to the central fixation. So this is a quick checklist to look into the field before diagnosing glaucoma. Look at the patient demographic, clinical picture of the patient. What is the type of test performed? Is the field reliable? Look for any abnormality. Is there any abnormality? Is it really significant? Rule out the chances of artifact. Look for any specific pattern of abnormality you see. So visual field findings have to be supported by clinical findings. If the test shows something you are not expecting, go back and look at your clinical findings again and then revalidate the test. Getting a good baseline report is important not only for diagnosis and management, but also for future monitoring. So these are my references. Thank you, everyone.